everybody. I'm Ron Waxman. We are at CRT Online. This is a series of COVID-19 interviews and discussions. And today my guest is Dr. Ian Meredith. He's the Chief Medical Officer of Boston Scientific and Executive Vice President. Welcome, Ian.
Welcome. Thank you, Ron. Thank you for having me.
Did I introduce you well, or did I miss something?
No, you did a wonderful job. You don't have to introduce me at all after all these years. I think our friendship goes for 25 years plus, so you can call me anything.
So that is correct. So those who doesn't know, by the accent, they can tell that you're from Australia. So currently, are you in Australia or you're in the US and you're Boston?
No, you see, I'm social distancing in downtown Boston. This is my wife and I share this wonderful apartment in Boston, although seeing the inside of the walls here for 3 weeks has become less than desirable.
So Boston hit, I think, pretty badly, even compared to other cities in the US and also compared to Australia. What do you hear from back home in Australia on the COVID-19 pandemic?
Well, it's an interesting story there. It's hard to know what the causes of the limited exposure has really been. But if you look back in early February, say between February 15 and February 20, there are about the same number of cases in the US as there were in Australia, in 15 to 19. And I think the following week, there were actually more cases in Australia. So, but there was an initial early rise in cases, and then they began phased social distancing, which became quite draconian in March. And now the case volume is very low. I think totally it's less than 7,000 cases in the country, and the death rate, thankfully, has been quite low. Now, exactly why there are these significant differences, I think there are many factors that have determined that on.
Yeah, have they started to open the country, or it's still stay home like you in Boston and me in DC?
Indeed, they've started to phase back recovery, and the federal government, I note in Australia, just a day or two ago, announced the reopening of hospitals for elective procedures and semi-urgent procedures. As we've experienced here, people with illness don't just suddenly disappear. They're still out there, and there's significant cost, of course, to having people trying to manage their cardiac and respiratory conditions at home. So the government have embarked on a process of opening up the hospitals to more elective or semi-urgent procedures, which is good to see that recovery taking place. So that, I think that starts on the 25th of April.
So that came to us quite a surprise, and I'm sure to all of you also who works with industry and trying to get things moving. Can you tell me what was the actual impact in terms of the pandemic on industry and maybe Boston Scientific specifically, as we were asked actually or ordered to stop all the elective cases?
Yes, thanks, Ron. It's a very important question, and I think most medical device companies have felt some impact. And of course, we've modelled worst case, base case, and best case scenarios for the rest of the year. But there has been a significant impact, certainly in April. Prior to that, there wasn't a huge impact. But as you can imagine, when you have a distribution of medical products, some that are used in the urgent setting, some in the semi-elective setting, and some that are truly elective, those more elective cases have been slowed down considerably as hospital resources have been utilised elsewhere, particularly PPE and ventilatory support. These things are being used elsewhere, of course, and appropriately so. So there has been an impact. We are unclear of how the recovery will actually be, but presume that the recovery will steadily take place from here based on the tapering past the peak.
Yeah, one of the issues that we are concerned at least in our institution with 180 patients, we still have room to do elective, although we are asked not to. But we have the capacity. The problem that I see is twofold. Assuming that the government or the local mayor will allow us to do it, there is a big fear of patients to come to the hospital right now. So we have to get some sense of security to patients that they can come back to the hospital to get their elective procedures, and tell them you probably are at more risk not being treated, not being seen by your caregivers, because many patients actually dying by not coming to the hospital and sitting on their STEMI, et cetera, et cetera. So I think that is our biggest challenge in terms of getting back to normal. Have you guys thought about this or partner with hospitals about trying to give this sense of security to patients?
Yes, actually, we have thought about this, and just to go over the point that you just raised, Ron, I think the reality is that burden and pool of patients with chronic non-communicable diseases has not gone away, and so there are still patients with significant heart disease and lung disease that are coping or barely coping at home. And as you rightly point out, we've seen in most cities around the world where the rate of death at home, spontaneous death at home, has trebled to quadrupled in most places, indicating that there are patients who've actually suffered in silence at home. Some of that, of course, is undiagnosed COVID. I totally recognise that point, but some of that, as you say, is these chronic conditions. So there has to be a point where we get back to treating these patients in a timely fashion. And as you well know, there are truly emergent procedures, and there's a very big pool of procedures in the middle, which are, you would call semi-urgent or intermediate acuity, and then there's low acuity illnesses. And it's that intermediate acuity, ultimately, if you leave it long enough, it becomes a significant problem. And that's where we've really got to direct our actions. So we are trying to partner in as many ways possible, whether it's through the support of protective equipment or for hospitals or centres, also trying to develop online education and training tools to assist physicians where possible, not to burden sites with our staff if we can do it by remote means. So we're looking at a number of different strategies. Internally, what are we doing? We're developing a very consistent, thoughtful strategy for how we manage our staff across the world through screening, questionnaires, personal protective equipment, thermal scanning, and ultimately when we have reliable tests and there's a significant pool of people with immunity, then we'll look at serological testing and other options as well. But we are thoughtfully, carefully going through every possible consideration to improve the recovery as safely and as effectively as possible.
Yeah, I mean, we in our institution decided that all the TAVR would be considered non-elective because, as you all know, that if we don't treat the patients with symptomatic aortic stenosis, the mortality rate can go up to 1 year of close to 50%. So we feel that you don't know when that's going to happen. So this is actually didn't impact much our TAVR program. We still didn't drop the volume on that one. Although again, I do sense that patients sometimes are in fear of not coming to the hospital because of the potential getting infected. And part of this is we participating in several trials, among them 2 trials. That one of them we are going to enroll within a few minutes into the Watch TAVR, that it's your trial. Another one was the Protect TAVR, which is also sponsored by Boston Scientific. But clearly the stay home, the non-elective procedure impacted a lot on research, and also you have to take into consideration that some of those patients that getting into the protocols may have a COVID-19 and may be infected, maybe they were asymptomatic infected. So how do you handle that right now from the research perspective? You have a lot of patients that are ongoing follow-up. You have patients that has to be enrolled. I know there were some guidelines from the FDA, but they didn't give a very clear direction what to do. So can you share with us, how do you, and you have a very robust research program at Boston Scientific, so how do you handle, what is the policy from company about a continuation of research during this period?
Well, thanks. So I think you outlined very nicely that the FDA did come out with some guidelines to provide direction on how research should be conducted in this period. As you can imagine, there has been a natural slowdown in the more elective procedures associated with clinical trial enrollment, but the two trials that you mentioned, particularly related to TAVR and Watchman, certainly still recruiting patients because the need is still there for the therapy and the devices. So what we are endeavouring to do is do as much remote monitoring of patients as possible, certainly not to place a burden either on the patient or our staff or your staff by adding to the mix of human interaction. And so principally we're working towards as much remote monitoring as possible and managing affairs that way, because I think that's really the primary approach. We're encouraging sites to recruit if they possibly can, but fully understand that they have to meet their primary needs and patient demands at each individual centre. So it is very much a centre-by-centre consideration depending on the burden of patients with COVID that they have at each site and their demand for PPE and other resources. So we are working with the sites as closely as we can to individualise and if you like, personalise the decisions so that we best help each research centre in a way that's meaningful for that centre.
Have you considered to change case report forms to capture COVID-19 presence in patients that are being enrolled or has been enrolled in the past and continue to be follow-up?
Yes, we are certainly considering that because obviously it's COVID-19 might affect the outcomes from the trials as well. It may result in increased and unexpected mortality or other cardiovascular or respiratory events or quality of life events. So it's important to be able to distinguish and pass out those events so that we understand what impact they have on ongoing trials. But you're right, Ron, this is a very important consideration that may compound the understanding of ongoing trials.
So maybe I'll ask you more specifically. I know, as I mentioned, Reprise 4 is ongoing, right? It's not stopped. Reprise, so that's about Reprise 4 with respect to Watchtower. It's investigator sponsored, but enrollment is ongoing on those centers that can do. Protect TAVR is ongoing. I know we're enrolling almost every patient, every day, at least a patient or two.
Fantastic. Very important trial.
What about Champion? Watchman is a little bit kind of more questionable whether it's elective or non-elective. What about Champion, if you can give us an update on that study?
So we plan to go ahead with that study. We're, again, very sensitive and conscious of the demands at each centre and the reprioritisation of staff and resources. And so we do plan to pursue this trial, and we hope to have first patient in the Champion AF study in the first quarter of 2021. We will be pursuing site selection and all the appropriate processes associated with that over the second half of this year. But again, very sensitive to whether sites can actually dedicate persons and time to meet those official requirements. And that'll be a site-by-site decision, of course, actually, Ron. And so, but the plan is to pursue that trial and to hopefully have first patient in first quarter of 2021. So from that perspective, we haven't deferred or delayed the study. We realise that naturally the process will be slowed over the next 3 to 6 months in all likelihood, but we'll just pursue it in a thoughtful way that doesn't impact too heavily on sites where the demand and focus is elsewhere.
Yeah, and you have also an ongoing study, I forgot the name, implanting Watchman after ablation or within ablation.
Option trial, the option trial.
So is that ongoing or that's on hold?
All those trials are still ongoing. As you might expect, Ron, the recruitment in those trials has slowed appropriately as there's been a shift towards fewer elective procedures and focusing more on the emergent procedures and indeed redirecting staff to the COVID efforts. So we understand that they've slowed naturally. We haven't formally suspended enrolment in those trials. It's just a natural process of those that can do are continuing, and those that can't, we wait and welcome them to the studies when they can.
So I have maybe 3 more questions. One is related to what is the expectation that you'll be able to return to almost, I would say, normal activities. It's not going to be that immediately normal, but let's say to 70–80% of the functionality. In terms of timeline, are we planning it still in the summer, or you think it's going to take longer than that? What is the plan at the level of a company corporate today?
So it changes every day, as you can imagine, as we learn more about the illness. But you're right, we model very carefully based on a number of international models as to what we think the recovery will look like. The one thing is clear, that there will be differences across the US, because we can see that the pattern of the illness has been quite different on the coasts compared to the middle of the country. And then even within neighbouring states, there's been a difference in the rate of rise and decline of cases. So our approach will be very state by state based and in accordance with government regulations and hospital regulations in each of those states. So we'll be guided by these regulations and these guidance documents, and be ready to serve appropriately where possible. As to what the timing of the recovery will be, we hope that there will be a recovery in the second half of the year, and most of the models suggest that, but again, a model is a model. It's only as good as the assumptions that are put into that model.
So third and fourth quarter would be much better than this quarter, I assume, right?
So we're modelling those scenarios of worst case, best case scenario, recovery in third and better in the fourth, modest recovery in the third and modest recovery in the fourth as the worst case scenario, and more rapid rise in the third and fourth quarters, approaching growth in the fourth quarter. We're looking at all of those options and functioning on a base case, so much along the lines that you've suggested, Ron.
Is there any product that was an opportunity to Boston Scientific? I know some companies like Medtronic and Philips, they have got into the production of ventilators. Some companies got into PPE. Is there any? You have a wide variety of portfolio, but I'm not aware of anything that was an opportunity in this crisis. I mean, maybe you can share with us, is there anything there in the portfolio of Boston Scientific?
Well, one thing that I'm very proud of is their association with the University of Minnesota to develop, and others, to develop a device known as CoVentor. CoVentor is essentially an automated ambu bag, so that instead of hand ventilating patients, we've created jointly a device that creates automated ventilation for a patient 8 to 24 hours. It is not the replacement for a ventilator. It's, if you like, an automated hand ventilation, just to reduce the human resources needed to ventilate patients, either coming off or going onto a ventilator. And that's in production now. We've done as much as we can with respect to PPE in terms of donation, and done a lot there. And indeed, we're assembling face shields and face masks at an enormous rate to distribute to healthcare providers and centres. And we've also donated the ventilators that we actually have had for clinical use. So while we don't formally have something that is immediately appropriate for this need, I think the Covent, or the development of that and the production of that, has been incredibly swift in under 4 weeks. And we'll produce around 3,000 of those fairly shortly.
And actually, thank you on behalf of the healthcare providers. About, I assume that all those PPE are coming from your production facilities and other resources, and it's so helpful here. Despite the stream or continuous stream of PPE, you know, there is never being enough is enough. And I know even here, which we are not in the apex of the pandemic, we still kind of, you know, looking very carefully, you know, to, do we have masks to replace every day? Do we have enough other PPE product? And I know that my son is currently works at Maimonides in Brooklyn, and they definitely don't have enough. So any contribution is really, really appreciated. Maybe I'll ask you the last question about the educational. We were all at the CRT 2 days before the first patient in our area that was diagnosed. And since then, it looks like most of the educational, or all of them, the cardiovascular educational meeting, put on hold. There is no official word on PCR, but it looks it's not going to happen. And ESC is also in question. And I want to go beyond it, not to upset anybody. But was there anything that on the plan from Boston Scientific to substitute some of those face-to-face meetings, the traditional one, with some other virtual or other opportunities to continue education?
Absolutely. And while I'm reluctant to say there's a silver lining to every cloud, perhaps the silver lining to this dark grey cloud has been the upsurge in digital education and the acceleration of processes that we already had planned in place to increase our digital and virtual education footprint, whether it be e-proctoring or whether it be meetings like this. And so we have a number of strategies across all of the divisions with a centralized infrastructure to build a much more sophisticated education and training portfolio capabilities, so that we can hold more meetings. And indeed, already we've been holding advisory board meetings and product review meetings and other fora using these sort of digital platforms, particularly Zoom and Teams and what have you. So I see this as a big part of the future, and I don't think it'll be a wave that comes and goes. I think we'll do more and more of this over time, because there are many virtues and benefits, particularly for busy physicians like yourself, Ron, rather than come to a meeting. If we can get 6 of you on the screen and we can all see each other as well as we can see each other today, it's not the same as shaking your hand, and I look forward to doing that. If we ever get a chance to do that again, it may be considered socially unacceptable to do that, but it's not the same as that. I fully agree, but it really has significant advantages to the busy physician if we can interact this way. And seek advice from you and also provide meaningful education platforms that you can use at will. So we are pursuing that, and we're pursuing that very aggressively and thoughtfully.
Yeah, and I agree with you. I viewed it as a silver lining because we developed a whole new educational communication tools that would change the way that we did business before, even the post-pandemic, because they're very useful. We handled yesterday our first journal club with all the fellows, and we had other people that we invited. We had in this region we call it the DMV, that's the DC, Maryland, Virginia. All the cat labs were participating in sharing cases and presentations. So we do it now on a monthly basis. We have over 75 participants for an hour and a half. We never had it when you do a dinner meeting. And more and more of these are actually can be shared. You mentioned advisory board. I totally agree with you. I know that this year you decided to skip one in April before even knowing the pandemic, but here we are. There is no reason why we cannot do it actually when we have maybe a little bit more time via those Zoom as we do it right now, one-on-one and other platforms. So I do think that there are some opportunities to continue to develop also training, showing cases. You know, there are some systems like Avail and the stores, I think, Carl stores, that are really building alternative to face-to-face meeting. And I don't think it's compromising a lot of the quality. Some of them are better because you see better, you hear better, you focus more. So there are some opportunities there.
I agree, Ron. I think there are some distinct advantages over face-to-face. And one thing I've noticed in an advisory board, because, you know, when somebody's speaking in an advisory board, everybody is looking at that person. But suddenly when you do an advisory board this way and you have a matrix that faces on the screen, you're seeing the speaker and you're seeing the reaction of all the others on the screen. And it is as though you're having multiple face-to-face conversations. So there are some distinct advantages. And I think, as you say, systems like Avail and others that provide so many modalities at once that you can look across the screen are really ideal for virtual proctoring and remote proctoring. So I think if there's one thing that's come out of this is that we've accelerated into a process that we would probably have naturally got there. We've just accelerated history, I suspect. That's what's happened.
Good. Well, thank you very much, Ian Meredith from Boston Scientific. First of all, I'm glad to see that you're in good shape and healthy, and I hope that everybody at Boston Scientific will remain safe and healthy. Thank you very much for sharing with us some thoughts during these challenging days. I hope to see you soon in person in the post-pandemic, although I enjoyed very much the interaction by the Zoom. Have a great weekend, and they will stay in touch.
Thank you, Ron. It's always a great pleasure to talk to you, and great pleasure to be part of CRT. And I look forward to seeing you face to face soon. Cheers. Thanks.
Bye-bye. Thank you.